Good morning again. I have a few housekeeping announcements and then I will turn it over to the rest of the day. As per yesterday, all the agenda items are in your folder. I want to call your attention to the IDW session that is happening at 11. The instructions for those are actually on your tables, and so during the break, I'd encourage you to kind of glance over them so that you're prepared for that session. And we'll be kind of consolidating tables at that point so that we can all be together for that interactive activity. Also, if you didn't have the opportunity to check in yet for today, we'd really appreciate you doing that, just because in order to have events like this, we need to keep good count of who's coming and making sure that they're able to attend. Lastly, we will also have the evaluation surveys that we really encourage you to do. We will be sending those out for the end of today, and so we'll have some time during our day for you to fill them out while you're here. But if you're unable to stay and do that, we really encourage you to fill them out, as again, it helps us to be able to have more of these types of workshops in the future. So thank you, and I will turn it over to Jane.
Thank you, Felice. And I want to start out with actually having all of us give a big thank you to the D&I Launchpad team, the other people who have helped, and to Felice, who's led this whole thing. And I'd like to give a big thank you to our D&I faculty, who fortunately have decided that it's worthwhile coming for day 2. So we are delighted to have folks back again and have our faculty back again. We are looking forward to today, where we're going to have a talk from JD on update on hybrid studies, and this will review go from what we talked about yesterday, that Dr. Kilbourne talked about, with really thinking about hybrid design across the continuum from clinical research to implementation studies and in between, and take us a little more in depth on that. Our second talk will be on how can implementation science support learning health systems. And the third, which I think will be really exciting, is Dr. Kilbourne will be talking about multi-level adaptive implementation strategies, which is really reviewing a little more. Also, there was a little bit yesterday on beginning to look at adaptive design and what that means when you think about how that approximates some of real-world implementation, where you start with implementation strategy A and then layer on implementation strategy B if A isn't sufficient. So finally, we'll end with a implementation development workshop that will help us sort of pull all of these ideas together over the last 3 days. Then we have adjourn, which before you adjourn, again, if you give your feedback, we really read it, we really look at it, and it helps us decide what people would like to hear more of next year. In the afternoon, for those who provided consultations, abstracts, we'll do small group consultations. So recap from day 1, we started out with sort of how do we start with real world implementation? Let's start by thinking about real world implementation and then think about the research questions around implementation. From there, the evaluation and optimization of your implementation strategies. So those are really all combined, and by thinking about them at the front end, we then come up with what's a research question for a research study. So our second presentation from Dr. Kilbourne talked about the replicating effective programs model and the enhanced REP framework, which looked at how you can actually scale up interventions into practice. And from there, going into hybrid design, it's how the different types of hybrid design help us think about organizing our research questions, understanding whether how to look at both implementation outcomes as well as clinical outcomes. And finally, a little discussion on looking at adaptive design and how that helps us design our interventions. And that was sort of reprised with a panel discussion, reviewing that further. And then in the afternoon, we talked about the logic model and got a chance to put together a logic model or think about putting together a logic model for different studies. And I think everybody heard from the panel as well as from beginning to work on it how important that is for guiding your work, evaluating your work, helping you make sure you're on path, and helping you get your grant. So from recap from day one, we're looking forward to day two, and I'd like to welcome JD. You're up. Thank you.
All right, I got to get the mic. All right, cool. Okay, is that okay? If I step back here? Okay, perfect. All right, we're good. Okay, so I'm going to talk about some updated thinking about implementation effectiveness hybrid studies. Let me go ahead and go through a few of these things. There's a little bit of general discussion about just implementation research designs, but the majority of this is going to be on hybrids. So I do want to acknowledge some funding sources, but also a number of these slides were created either by Jeff Curran and Sarah Landis or co-created between the three of us or Dennis Lee. So we've all done different workshops and presentations on hybrid studies in the last couple of years. So I pulled together things from all of those sources. Okay, so why hybrid studies? So the initial idea really was to condense the translational research process, where there had always been sort of a perspective that translational science was in some ways sequential and happened in steps. So the idea when you move from efficacy of testing and intervention, that you then start to do effectiveness research, and then you then do implementation, and then you do scale up, is essentially the final step. And Jeff Curran and all the folks who wrote the initial flagship paper in 2012 on what they called hybrid trials at the time was really trying to start to infuse implementation-related questions into effectiveness research, okay? People have actually started to put implementation questions into efficacy research, but that's still, fairly novel, I think, or at least a little uncommon. So the idea really was, again, blend these different questions into the same study with the purpose of saving time. So instead of doing an effectiveness study, then doing an implementation study, we're able to do two things simultaneously and move through translational spectrum quicker. One of the key pieces, too, is that in this type of thinking, we don't necessarily have to wait for perfect effectiveness data before we move to implementation research. Okay, so some of the, again, I don't know if this is still part of the contemporary thinking about why we move and when we move into implementation. But it used to be that you needed to have kind of two effectiveness studies. You said, one really good study, replication of that study, then it's like, really indicated that you move into implementation. But in this perspective, as soon as you have an intervention that is likely to be effective and you have solid data, you can start to infuse implementation research questions, okay? So you don't have to wait. The other thing that's kind of interesting, and I've seen this a few times, and I'll give an example of when this happens, we can also do what Jeff called backfill effectiveness data. So in certain situations, and the best example I can give that we're unfortunately all aware of was vaccines for COVID. Vaccines for COVID went through safety testing and efficacy testing, and then immediately went into implementation. So they did not wait at all for effectiveness data, but they gathered effectiveness data at the same time as they were implementing because there was a public health imperative. I'll pick on Amy for a second. Well, not you necessarily, personally, but the VA is also notorious for having an effective practice from a really, a trial, a very well established, well done, rigorous trial, and then saying, now we're doing this. And so there's some really good examples of not having effectiveness data, but yet there's a mandate that says we need to all do this. And so you're figuring out the implementation at the same time as you're basically gathering the effectiveness data and showing that it still works once it moves into regular practice. There's a lot of other places that do that, but the VA apparently does it a few times, has done it a few times. Okay, so the other question too about why would you want to do effectiveness and implementation simultaneously is that there always is a relationship between implementation and effectiveness data. Anybody who does efficacy and effectiveness understands the relationship between fidelity and outcomes. That's just one implementation process or one implementation metric that is related to the effect of the intervention. But all the things that we talked about yesterday, reach, adoption, all those pieces obviously do contribute to the overall effect of an intervention as well. And how do you know, essentially the variability and how implementation relates to the overall outcome of the intervention if you don't have data from what Jeff calls both sides, effectiveness and implementation, okay? So doing hybrid studies starts with a focus on the outcomes that you're trying to achieve. Really, the saying of knowing where you are going is the first step to getting there is really important in deciding if you're going to do a hybrid study and which hybrid study type you're going to do. So one thing that I really like this figure that was by Megan Lane Fall, Renat Davis, and some other folks at Penn, and actually Jeff was on this paper as well, that really, this is what they call a subway model, okay? So at the beginning, you identify the practice of interest or the intervention that you are interested in studying and implementing. You ask a couple of questions to take you down which part of the pipeline, and I'm going to go down the pipeline or the subway that takes us to hybrids. But essentially, if your POI or your practice of interest has shown efficacy data, you start down the yellow path. Has the POI shown effectiveness? So have you done an effectiveness study? Yes or no? Either way, at that choice point there, whether you have no effectiveness data, whether you have partial, or whether you have done an effectiveness study and shown that it works, you're starting to get into the potential of using one of the hybrid types. Okay, the best place is really the bottom two in the green. Those are the main places where it's indicated to do an effectiveness implementation hybrid study. However, in the no data of effectiveness, I think that is sort of a question that should say maybe. Shouldn't necessarily just be a total no. Because again, you can backfill effectiveness data and there are situations where it's sort of necessary or indicated that you do so. Okay, so types of hybrids. This looks very familiar to what Amy presented yesterday, but I'll go through it in a little bit more detail. So essentially, the hybrid types are on a continuum. We use the type 1, type 2, and type 3 really as sort of shorthand, so that when I say type 1 to anybody, they have a pretty good idea of what I'm doing. Jeff jokes sometimes that we should have hybrid type 1.67s, 2.4s, those kinds of things, because every study really does exist on this continuum. There is no perfect type 1, there's no perfect type 2. There are lots of decisions that you make in the conduct of a hybrid study that sort of puts you someplace on the continuum. But roughly speaking, as a heuristic, we use type 1, type 2, and type 3. Okay, so the next couple of slides I want to note are sort of the original conception of hybrids, and then the later slides are going to kind of offer these new thoughts and extensions. So the hybrid type 1, you can see our main focus here is really on the intervention effectiveness. Implementation research questions are also relevant, but they are less central and typically are not tested in the context of a hybrid type 1. Hybrid type 1s test the intervention and they gather information about implementation. So often it's observed, often it's just documentation, it's process evaluation. There's multiple ways to do it, but really you are doing and designing a research design that is going to test the intervention's effectiveness as the primary, okay? These are often person-level randomized controlled trials. So that's kind of the classic, is to do that. And your primary outcome is going to be intervention effectiveness. But we add the plus of doing implementation-focused process evaluations. We evaluate the implementability or scalability of the intervention. We also examine the implementation determinants, what things serve as barriers and facilitators during our trial. You're often using mixed methods as part of this approach. And this is not an explicit evaluation of real-world implementation strategies, but essentially you are trying to use more typical implementation as usual strategies in most of these situations. So let's go to hybrid type 3s on the other side, just to give the contrast. So in a hybrid type 3, implementation research is the primary research question, and our research design is going to follow along that question. So here, we're doing exactly the opposite. We are testing the implementation strategy, and we're gathering information about the intervention effectiveness. It's a little bit of a tricky thing, and we'll talk a little bit more about what that means to gather information on intervention effectiveness. But so these are often going to be cluster randomized controlled trials for the implementation strategy. And part of that is because almost all of our designs involve clustering, and we're intervening at implementers, service delivery agents, clinics, systems, things like that. So those become our unit of randomization. I'm not going to say you never see an individual level randomized controlled trial as a type 3, but it's rare because it just doesn't make a lot of sense in most situations because your strategies are going to be targeting a different level and you need to have a cluster randomized trial. Your intervention outcomes are always secondary in a type 3. Things like stepped wedge and other rollout designs are common here, but that is certainly not the only type of research design that you're able to use. And depending on the type of intervention, the collection of effectiveness can be a challenge. So in many of these type 3s, the scale is huge, okay? We're talking about, we have a hybrid type 3 that is doing county level randomization in 66 counties across the United States. The amount of data that gets collected and the diversity of data systems in each of those counties makes it very difficult to collect the kind of gold standard effectiveness data that you would do in an efficacy trial. But good luck. But it's not an efficacy trial, so it's okay. So what we're doing is actually getting more proxy level data that is still indicative and it's sensitive enough that we know whether we had an intervention effect, but we're not doing the same kind of thing that we would ever propose in an efficacy or even an effectiveness study because of the scale. We are often doing costs of the outcomes or cost of implementation strategy. Sometimes it's cost to achieve outcomes. So we do, dollars, the amount of dollars that it takes to actually reach 10 individuals with this intervention, things like that to be able to do comparisons. And it's emerging that people are doing tests or trying to understand the mechanisms of the implementation strategies within hybrid type 3s. Okay, so what about the middle? So in a hybrid type 2, we have co-primary aims. Doesn't really matter which one goes first, whether it's the implementation research question or it's the effectiveness research question, but they are technically co-primary. I typically give guidance that if you're applying for a grant that is very clearly an RFA about implementation, lead with the implementation question, even though they're co-primary. If you're applying more to an effectiveness type panel or one that's more likely to be reviewing clinical trials, and you happen to be one of the weird implementation people who's applying to that panel, I've been that guy a few times, then lead with the effectiveness question, but still noting they're co-primary, okay? So in this type, you are testing both the intervention and the implementation strategy. Amy did mention yesterday that there is sort of a subtype. We've never actually officially labeled this a subtype, but there's a situation in type 2s where you have a research design that is powered to test effectiveness, and your implementation is more of a pilot implementation strategy. So you're not necessarily testing an implementation strategy in the same way that if you had two bona fide strategies and you do comparative implementation. Usually it's a pilot strategy compared to implementation as usual. And that's sort of again, kind of a subtype of hybrid type 2s. So in this case, you're going to examine the performance of your intervention and implementation strategy simultaneously. Your implementation strategy is explicitly hypothesized to be real-world ready. So this does go back to a couple questions we had yesterday about sort of the generalizability, the scalability, and the sustainability of the implementation strategy itself. In type 2s and type 3s, you really need to be proposing strategies that are adoptable and sustainable by the system, and you're not infusing a ton of expertise, resources, those sort of things to make this happen, which is more appropriate for a hybrid type 1. And we are typically focused on hybrid type 2s in doing summative implementation outcomes like reach, adoption, fidelity. These are sometimes also called objective implementation outcomes rather than sort of the perceptual or ability outcomes like acceptability, appropriateness, feasibility, sustainability. We're still interested in those things, but typically we've already established that our implementation strategy is feasible in a type 1, and now we can move to a type 2 and answer more objective questions. I already mentioned the pilot version. The more elegant, but obviously less common research design in a hybrid type 2 is what we call a dual randomized version. And there are examples of this, but as we talk about what they are, you'll see why there's not very many. So this is typically testing and comparing interventions and implementation strategies simultaneously. So a really good example was done by Brian Garner and colleagues, where they had substance abuse clinics that were randomly assigned to an implementation strategy, either A or B. Both were bona fide evidence-based strategies, so they were supposed to be likely to be equally effective. It was more of an inferiority or non-inferiority design than it was an inferiority design. And then those sites were also randomly assigned to which intervention they were going to provide. And there was, I want to say 28 clinics that were in that trial. So you had all the combinations of the different strategies with the different interventions to figure out which one was the best. You can see why that design doesn't happen that often. They're just very challenging and can be obviously fairly expensive depending on the nature of your implementation strategy and your intervention. Okay, so in 2019, Sarah, Jeff, and Sasha McBain published a paper in a special issue of Psychiatry Research, which if you haven't actually seen this special issue, it's awesome. I'm not saying that because I contributed a paper in it, but it is a really, really good kind of introduction to all the key methodologies of implementation science. And there was a paper on Introduction to Hybrid Effectiveness Implementation Design. However, here's the things that kind of come from the 2019 paper that advanced the thinking from 2012. So some of the things that were put out, and I mentioned one of these things yesterday, is that hybrid type 1s should be less of a special case and more routine. So Jeff will actually say there's no place for an effectiveness study. Danny disagrees. I kind of disagree too, but I see that, I think that should be the rare case that you do a pure effectiveness study without thinking about anything related to implementation. And then Jeff did note too that they have seen folks doing hybrid type 1 work in efficacy research. So actually starting even earlier to think about implementation questions. And there's also a thing that they call type 1 pilot studies, which they define in this paper, but they're still fairly rare. And those are really sort of very minor pilots or small pilots of an implementation strategy. So there's something that instead of just observing and gathering information about what's done, you're starting to actually kind of do a little bit of a protocol, typically based on what you did in an effectiveness study. A couple of other key points about hybrid type 2 point is that your type 2 needs to be fully justified and include fail-safes for if one of the implementation strategies does not work, okay? And what they talked about was the recommendation that you build in time and have specific data collection to iterate strategies if needed. Because in some of these type 2s in the early days, they found that the implementation strategy was just simply not effective, but then the trial continued and they had a null finding, but they knew within 6 months that what they had proposed was not going to work. So that was recommendation for that. Hybrid type 3s, they also questioned whether they should be a special case. Essentially, why wouldn't you want health outcome data, right? So kind of questioning the value of doing what we would call kind of a pure implementation study, which means you only get to the implementation outcome and you don't still collect data on clinical effectiveness. So really kind of asking the question, when would you ever do that? Some of the data, as I mentioned, is hard to get in hybrid type 3s because we're not doing the same kinds of assessments as we typically do. But folks have done some really cool things using like administrative records, using like CDC surveillance data around HIV infection, to show that their intervention has still maintained effectiveness. Again, not nearly as sensitive or as specific as we would typically do for an effectiveness or efficacy study, but it's good enough data to show that the intervention was effective. And then the question too about, this whole relationship of implementation to effectiveness outcomes, shouldn't we want to prove how much fidelity is important and under what circumstances? And you could replace the word fidelity with any other implementation outcome. So how much reach is actually necessary to have a population level impact? How much adoption can we actually achieve without doing X, Y, and Z additional implementation strategies? And actually proving those things during a hybrid type 3 is important. So let's get into the more recent reflections. So this is a paper that we published actually almost exactly a year ago. This was November, December, 8th of December, 2022. And this was sort of our 10-year update. So the first thing, are they really designs? So in the initial paper, they had been called trials because they were specifically trying to influence people's trials. It was meant to be more clinical trial focused. There wasn't really anything related to public health or community-based interventions or structural interventions that was mentioned in the 2012 paper. In about 2016-17, Jeff and colleagues started adopting the term designs instead of trials because you don't have to use a trial research design as part of a hybrid, but hybrids could be sort of thought of as a design. We actually decided to change that in this 2022 paper. So it depends a bit on your definition of design. So myself and Hendricks, Brown, and a couple other people had come up with what we thought was really some of the defining characteristics of research design, which is really the planned set of procedures to select the subjects or units for your study, assign them or observe them in their natural conditions, and to assess before, during, and after assignment in the context of a study. Those are some of the very, very basic things that constitute a research design. But the 2012 paper focused on trials, and that was too limiting. So a lot of folks in public health, initially were like, does this even apply to me? And so there was really a thought to try to expand. So you don't have to randomize, and you don't have to do a trial to be doing a hybrid. And so really what we decided to go with is hybrid studies. So all of these are hybrid studies. And it's really important to kind of clarify that for another reason that we'll talk about in question 3 or 4. So question 2 was better guidance about which hybrid type should I use? That was one of the very first questions that typically comes up when someone asks for consultation about hybrid studies is, well, which one? And the question is, I don't know. You tell me, basically. So we put together actually this little worksheet for folks to go through and answer questions typically about the evidence for both the effectiveness intervention and for the implementation strategy to help you decide which of the hybrid types was actually justifiable in your situation. So I'm not going to go through every single one of these, but essentially, again, we ask the nature of the effectiveness data. Do you have effectiveness data? Has it been shown to be effective in more real-world settings? And if you have it, you potentially can do a type 2 or type 3. If it's either mixed or not very strong, you can consider type 1 or 2 more likely. So how much do you think the intervention will need to be adapted where you want to do it? So I did a study a couple of years ago where we adapted an intervention that had previously been delivered through home visiting and in school-based settings. And we were going to do it in coordination with primary care. And also we changed the target from child behavioral problems to pediatric obesity. So we had to do a fully powered type 2 that tested both the intervention and the implementation. It would not have been appropriate for us with that level of adaptation to jump to a type 3. And we also thought that it was sort of a waste to do just a type 1 because we actually had effectiveness data on obesity and we had a pilot implementation project that had shown to be feasible. And so we justified jumping to a type 2. Okay. Other questions that we ask is how much do you already know about the implementation determinants for the intervention in the context you are going to implement? So if you have really good pilot data and you know the barriers that you're going to face, it's more likely that you can jump to a type 2 or type 3. However, if you really didn't do that kind of work in any of the pilot work or in your effectiveness study, you're likely to probably be doing a type 1 because again, we're documenting process and understanding barriers and facilitators in a type 1. So you kind of have the opportunity to collect this data now. Fourth question is, how ready are you to evaluate a real world implementation strategy or package of strategies? So if you're really not ready or your implementation strategy is not very real world at this point, you're probably likely to be doing a type 1. And again, understanding the determinants and developing strategies to test in later hybrids. Or if you have some of that data, you can consider doing a type 2. If you are definitely ready and have done a strong pilot, or maybe you've already completed a hybrid type 1, and your effectiveness data is really strong, and you don't need to adapt a lot, you can do a type 3. So this is all in the paper, and there's a couple other kind of interesting things too to help people decide about hybrids. But this was just guidance that we wanted to give the field since it's a prevailing question. So what research design should I use? Okay, so we've already established that saying I'm doing a hybrid design is not actually what you're doing. Because I can do a hybrid type 2 using a ton of different research designs. Okay, so that was one of the reasons we went to calling it study. But there's still the question of, if I'm doing a type 2, what research design should I use? And I have actually heard people say, if you're doing a type 3, you have to do a cluster randomized blah, blah, blah. I'm like, no. Type 1, type 2, type 3 does not tell you anything about your research design. However, your research question should. This should completely be derived from your overall research question. So there are some research designs that are sort of lend themselves better to different hybrid types. So with type 1s, we often favor outcomes at the person level or the client level. So a lot of the studies use individual level randomization. However, type 3s typically favor place-based implementation outcomes. So these will include cluster randomized designs that have a place level focus. Okay. Hybrid types 2s blend the two, and so the relative emphasis on either effectiveness or implementation tends to drive the design choice. And so, in certain situations, if you do a cluster randomized design for your implementation outcome to test the strategy, you can still do clustered effectiveness data and test the effectiveness of the data. In observational designs, non-randomized studies, and designs that are used for formative and pilot work, like pre-post interrupted time series, some of these not quite as rigorous designs, we typically would use, you could use these for any of these, honestly. But they're not common for like larger R01s and anything where you're really trying to formally test something. Observational type 2s and 3s have occurred in healthcare and public health systems, typically evaluating or using rollout designs that are not designed to be, looking for causal inference. A really good example of observational studies is when a policy goes into effect. And you look at the implementation of a policy, whether it changes practice, whether it improves outcomes. There's no randomization typically in that. It's just an observational study. And the type 2 or type 3 sort of depends on the evidence for the effectiveness of the intervention that's being mandated, and of course the implementation strategies that are being used. Okay, another thing that we wanted to address are what are some challenges with this hybrid typology? So it was set initially with a clinical research mindset. I've kind of already mentioned that. It doesn't work as well for health promotion and public health type interventions. In part because little efficacy sometimes in the real world implementation and the strategies. And you're not sure if the types fit for policy research as well. People have applied it to policy research, but it's definitely not as good of a fit as it is for kind of more traditional clinical research. Again, I already kind of mentioned this, that the actual type 1, 2, and 3 really is a shorthand so that we can talk and I don't have to explain with 10 sentences what I mean by hybrid type 2. We kind of all understand what that means, but it doesn't capture nuance. So I jokingly, with my very first implementation trial, that was a hybrid type 2, when I talked to Jeff about it, that was the question I asked him too, was what type is this? Because we designed a study and didn't actually name the type. And he was like, well, it's kind of a type 1 and kind of a type 2. So maybe it's like a 1.5. And I was like, okay, well, I'm not putting that in the grant. But again, it was like really acknowledging that, you don't fit perfectly in either one of these. There are aspects of the research design and the research questions that are a bit closer to the type 1 and some that are closer to the type 2. And so we ended up calling it a type 2 while acknowledging the things that were a little less type 2-y. So obviously the other thing that's a little bit interesting about these is that not everyone agrees on what the thing is. Remember the thing from yesterday with Jeff's slide, the thing you're trying to implement? There are situations where people are trying to implement an implementation strategy. Just got really meta, sorry. But that happens, okay? And whether that actually constitutes, is that a hybrid then? Because an implementation strategy is not meant to change health outcomes directly. Can you still apply hybrid typology when you're trying to implement something that's not an evidence-based health intervention? We did actually in this paper say that you can, but that you have to be very, very clear about what is effectiveness. Is it effectiveness of the implementation strategy? Are you going to look at the full downstream effect of the effectiveness of the intervention that's being implemented and supported by the strategy that you're testing the implementation of? Got really meta again, sorry. The other thing is adjunctive interventions. This is a new term. We have a paper under review that talks about these, but they're these weird things that are kind of in between strategies and in between health interventions. The easiest example is something like an adherence intervention. Okay, so I can do an intervention on somebody to do blood pressure medication, but that in and of itself, if they don't take the medication, they're not going to change their blood pressure. Okay, so an adjunctive intervention does not directly lead to the health outcome, but it could be something I'm trying to implement. And it could apply, but yeah, it just takes a little bit more explanation to actually do that. We are still recommending using the typology, but using language that's a little bit less definitive. So saying this is like consistent with the goals of a type 2, rather than saying this is a type 2. Because again, the nuance is important, and really explaining how exactly what you're doing and how it fits is critical for reviewers and readers to understand what you did. Okay, the other question that often came up is how are costs analyzed in hybrids in general, not specific to type? So in the field in general, there's increasing attention being paid to the cost of implementation strategies, not just the cost of delivery of the intervention, which we've been doing for a long time, and not like healthcare utilization reductions or things like that that are certainly relevant still, but really more of a focus on what does it cost to actually do rep? What does it cost to do getting to outcomes? What does it cost to do practice facilitation? And then incorporating all of those things into an overall costing approach. So in hybrids, it's not always easy to do. And this is in general for all implementation studies. To really get good cost data, we use pretty rigorous methods like time-based activity-driven costing approaches and micro-costing methods that are a little bit onerous and sometimes annoying to implementers. So to get really good data is sometimes a little bit hard. So cost effectiveness analysis can be done in all hybrid types, and there really isn't different ones necessarily for each one. You do want to include implementation costs in any conventional cost effectiveness analysis, and this is just a recommendation that we've seen sort of not be consistent in the literature, where people have not been explicit about the implementation costs. I actually reviewed a paper not too long ago that was testing implementation strategies, and they only reported the cost of the intervention delivery. Not the training, not the audit feedback, not all the other strategies that they had employed. All of that was actually left out. Not good. So the focus of any cost effectiveness or cost analysis of implementation strategies is typically done on increments of one of your implementation outcomes. So in most situations, you're wanting to see, especially in comparative implementation or in a type 3 where you really are testing a strategy against something else, you really want to see what's the incremental achievement of certain implementation outcomes between strategies. And there's ways to do this, but with traditional cost effectiveness analysis or a thing called ICERs or incremental cost effectiveness ratios, which really can say, adding this additional strategy. So if you're doing a factorial design or something where you have kind of combinations, you could say adding this additional strategy gets us this X number of people, and we can convert that to say to achieve 10% or 10% increase in the adoption rate, it cost us X dollars. And that was basically the cost of that implementation strategy on top of a bigger package. So ICERs can be really important to really figure out, is this actually a cost-effective implementation strategy? Oh, I like this recommendation. Seek professional help. This section was written by a health economist who works with implementation scientists and I think encounters a lot of problems when people try to do their cost stuff on their own. So definitely work with a health economist and a health economist who's interested in this. I'm not knocking health economists. I have 3 that I work with very closely, and I love all of them. But not every health economist is actually interested in implementation costing, because it's very different from what their traditional methodology really is. Okay, they're used to like societal perspective, all sorts of different kind of big models, and we're like, what is the strategy cost, and how much is it going to cost one implementer to pay for that strategy? I don't know. It seems kind of small for some economists. I don't know. Just make sure they're okay with it. And there are more and more examples of cost effectiveness, ICER, and other like opportunity cost and return on investment evaluations in implementation science. And I think it's becoming one of those things that is literally going to be almost required, but certainly expected in years to come. Okay, I'm going to skip over these last ones. This is just a helpful heuristic for kind of thinking about, sort of in implementation work versus in effectiveness work. Where do we fall on the hybrid type 2s and type 3s and type 1s? But yeah, just another sort of visualization versus the pendulum on the fulcrum. We have a few minutes for questions before I go over my time. I don't know if there's a microphone. I don't see a microphone. It's got to be out there someplace. Oh, Elisa? Yeah. Raise your hand high.
Thanks so much, JD. That was great. All right, so I have a question about the whole real world topic.
Yeah.
And it's a multi-component question, so just bear with me as I try to
Sure.
knock these out. Okay, thanks. All right, so, the first question is really, are we focusing, or should we be focusing on whether it's the implementation strategy that's reflective of real world or the intervention itself? That's part A. Part B is, how do we know if we have enough evidence to show that part, those two things, whichever one is real world enough? Okay, that's B. And then C, if we're really focusing on the implementation strategy, given that Eric already lists like a gazillion strategies that I believe are already evidence-based.
Evidence-informed is what I said.
Evidence-informed,
Yeah.
okay. Then would that suffice to show, hey, we already have enough real-world evidence to support that implementation strategy, or do we need more evidence in our particular clinical context
Yeah, good question.
to show, all right, so it's like A, B, C, D.
Yeah, so A, yes. B, no. So A, yes, you do need to have real world both for the intervention and the strategy. When we're really talking about differentiating and trying to decide which hybrid type, it's more focused on the strategy. So usually in effectiveness research in a type 1 hybrid, you're still probably establishing whether or not there's feasibility, adoptability, scalability of an intervention to say whether it's real world. So all those characteristics, of course, contribute to whether it's real world. But really in the typology of, are you ready for a type 2 or a type 3? It's more focused on the strategy with sort of the underlying assumption that you've already established that the intervention's real world if you're even considering a type 2 or type 3. That's the short answer. So for your second question, this one was about evidence. Okay, yeah, sure. So that is kind of a tricky one. So this is definitely an it depends question. My general perspective on this is that the establishment of real worldness of implementation strategies and having enough evidence that you're ready to use that in prime time essentially is that you have to show context, intervention, and evidence triangulation. Meaning that the evidence for the effectiveness of this implementation strategy really should be directly about your intervention and in the context that you're delivering it. If you can hit all 3 of those things, then it's great. I definitely have seen though, and done it myself, where we've had two of the three. So an evidence-based implementation strategy, it's been shown to be effective with behavioral interventions delivered in primary care, but not with my behavioral intervention. But you can make the case oftentimes that my behavioral intervention shares the same characteristics as these 4 other studies that use the same strategy in primary care. So you can make that extension in places in the literature where there's really good evidence. But yeah, you really have to sort of establish all of those pieces. So your question about when do I have enough evidence, that is a really hard question, and in part because it's sort of field specific. So, I had the example earlier of, having COVID vaccines get rolled out and implemented. And that was really kind of a type 3 type of thing. It was really like, okay, we know this is like at least effective a little bit. We're going to really study how to implement this and try to get as many people to take it as possible. That is a totally different situation than what most of us are sitting in. So in psychology, for ever and ever in clinical psych, the gold standard before you even move to implementation was efficacy study, effectiveness study, and a replication of that effectiveness. And if you don't have that, the perspective was you're not ready to do implementation science with it. But every field is a little bit different, and also there's often these contextual factors that are driving a need to move interventions into the real world that you can kind of leverage and say, hey, they're going to do this whether or not there's enough evidence or not, and we need to study the implementation. And that was really the case for a lot of the COVID interventions and others. So it's a really difficult question. There's actually a really nice paper by Ross Brownson and colleagues that came out really recently that actually, I think the title is something like, "What is evidence in implementation science?" And it does go into some of these questions about evidence for the strategy, evidence for the intervention to actually move into implementation, and sort of how do you get that evidence in ideal circumstances and then sort of less ideal circumstances. So a really, really nice paper. We'll take a look at that question. I think I'm right on time, unless there's a really quick question. Okay, good. All right. I will pass the mic.